Hello, my name is Camilla. I'm consultant midwife at East Midlands Ambulance Service and lead midwife at London Ambulance Service, and I'm presenting this webinar alongside Gavin, Susan and Orla. Together we have reviewed and updated the Imminent Birth Guideline with input from colleagues from the RCOG, College of Paramedics, the RCM and JRCALC. We would also like to thank the leads that sit on the pre-hospital maternity and newborn care group that have been involved in reviewing and updating this guideline. This guideline refers to head-down births, so if you are faced with a breech baby, then please refer to the breech birth guideline. All of what is contained within the guideline is summarised in the algorithm, and we would recommend that the algorithm is what you get out on scene at a birth to make sure that you're following what is contained within the Imminent Birth Guideline. The updated guideline covers history taking, assessing whether birth is imminent, preparing for and supporting a birth, optimal cord clamping and managing the third stage of labour, maternal and newborn observations and care at birth, transport and monitoring, and then we also have covered various special circumstances, for example, multiples, preterm birth, water birth, on-call, amniotic sac presentation, free birth and home birth. We would recommend that you use this guideline alongside local guidelines which are available for you on JRCALC+. You also need to use clinical judgment and shared decision making, which we would recommend to be within the pre-hospital setting, within your clinical hubs or critical care desks if you have them available to you. When you arrive to somebody in labour, you'll need to take a quick history from them. You may need to consider whether you need an interpreter to do this. So we need to know the number of weeks gestation she is, whether this is a multiple or single pregnancy, the number of pregnancies that she's had, which we refer to as gravida, the number of live births that she's had, which we refer to as parity. It's helpful to know whether any of the modes of birth have been caesarean section. Has she got any medical conditions, any complications in current or previous pregnancies? Has she had any bleeding? Have her waters broken? And when did they break and what colour are they if they have broken? And are there any concerns voiced by the patient or the family? In terms of assessing contractions, I'm going to talk you through what normal contractions look like. So a normal contraction will rise, peak and fall, and often women are not able to talk or engage in a conversation during strong contractions. Between the contractions, they should have what we call resting tone, which is where the pain decreases and they feel nearly back to normal. Some women who are contracting very often may say initially that the pain is continuous, but what we need to identify is, are there gaps within the pain that she's having? A normal contraction normally lasts about 60 seconds in duration, and in established labour they'll be coming every 2 to 3 minutes. What we need to do is assess the time difference between the contractions. So we're looking at the interval from the end of one contraction to the start of the next contraction. This would be normal labour. However, during normal labour, although this isn't an obstetric emergency, we would recommend that the woman has fetal monitoring. And so we would recommend that these women are transported to hospital for that fetal monitoring. In terms of time critical conveyance, if there are any of these risk factors, which I'll go through now, then we would recommend that this is a time critical conveyance to hospital. If birth is imminent within any of these factors, then the imminent birth overrides the risk factor. Following the birth, the risk factor will need to be considered and acted upon as soon as possible. So any bleeding after 20 weeks is always a time critical conveyance. Any blood-stained liquor or amniotic fluid would also be time critical. If there's meconium-stained waters or offensive smelling waters, these are also red flags. If there's constant pain and you don't get the dip in the pain between the contractions where the woman doesn't feel pain, then that would be known as poor resting tone, and that would be a red flag. If the woman has had a previous cesarean section and she's getting any scar pain, then that is also a red flag for time critical conveyance. Any signs of labour prior to 37 weeks would also require time critical conveyance. Please be aware that preterm labour can sometimes present atypically. This means that the pain may not be as regular or as strong as term labour being from 37 weeks onwards. So it may be that the woman has signs that relate to a urinary tract infection or back pain, but these should be considered as preterm labour unless proven otherwise by a hospital. Any observations outside of normal parameters should also be considered, and we would recommend that you use the pre-hospital maternity decision tool for the parameters which are normal during and following pregnancy. High-risk pregnancy should also warrant a time-critical conveyance even if the labour is normal in presentation, and the new guideline has a table which shows what counts as a high-risk pregnancy. The quickest way to identify this is normally to ask whether the woman is under obstetric-led care, but there are other risk factors listed there on the table. As I mentioned before, if birth is imminent and one of these things is identified, then the imminent birth overrides the risk factor and you would consider staying on scene. In terms of the decision to stay on scene, this is nuanced, and the new guideline tries to talk you through how to identify whether you stay on scene and recommends that you do a continuous dynamic assessment. So in general, as per the previous guideline, if contractions are coming with a 1 to 2 minute interval and you have either an urge to push or the presenting part is visible, then you would stay on scene and prepare for birth. With regards to the presenting part visible, we would recommend that you observe with consent during a contraction to see if you can see the top of the head. These pictures show the difference between the presenting part being visible and crowning. When the presenting part is visible, the head may actually recede between contractions, and this is normal. And so within each contraction, at the height of the contraction, the head will be visible again. And hopefully you'll be seeing more and more of the head with each contraction. With crowning, this is where a crown would sit on your head. The head remains visible and doesn't slip back in between contractions, and we predict that the baby's head will be fully born within the next contraction or so. If you arrive to scene and you've assessed that the birth is imminent, because she's having contractions every 1 to 2 minutes and she's got an urge to push, or you can see the top of the baby's head, we want you to prepare for birth, and Susie's going to take you through that shortly. What we want you to do is make sure that this is a continuous dynamic assessment of whether you should stay on scene or not. We want you to reassess for progress at least every 10 minutes and change the plan if you're not seeing progress. And this includes the same amount of presenting part visible. Obviously, when you are extricating and transporting, things may change and the baby may become more imminent and birth. So we need to be prepared at all points during extrication and transport for this to happen. The reason why we need it to be a continuous dynamic assessment is because sometimes with your assessment, the woman will have an urge to push and regular contractions, but the birth may not be truly imminent. So this can happen if the baby's head is malpositioned. It can be that a woman can get a premature urge to push. And with presenting part visible, sometimes it presents to a certain point, but then we'll need intervention in a hospital setting for the whole birth to be completed. So this may be if the woman has female genital mutilation, or if she has a full bladder. These things will be requiring intervention in a hospital setting. And this is the reason why we want to you to do a continuous dynamic assessment when you're deciding to stay on scene. In a hospital setting, during the second stage of labour, when a woman is pushing and birthing, we would listen to the fetal heart at least every 5 minutes, if not sooner, or in a continuous way. In a pre-hospital setting, we don't do fetal monitoring, and so the baby in a pre-hospital setting won't be getting an assessment for hypoxia. Therefore, we want to minimise on-scene time if the birth is not truly imminent.
In this part, we're going to talk about managing the birth and the initial steps that we can take. First of all, we're going to plan. We're going to call for help, and we're going to try and ensure that we have enough resources. Ideally, at least one paramedic clinician dispatched across one of the vehicles. Use your personal protective equipment, and this might mean aprons, gloves, eye protection, sleep protection, and any other universal precautions. Ideally, identify a lead clinician for the patient and for each expected baby if possible. If this is a planned home birth, then request a midwife from the patient's home birth team. We understand that the midwives will make their way to the scene under normal road conditions, so be prepared to facilitate birth in the absence of the midwife. As part of your care, introduce the team and establish a rapport with the patient and their family. Have a calm and gentle approach to your communication. Allow the patient to adopt a position that's most comfortable for them. It's not generally advisable for them to lie completely flat on the back. Allow the patient to spontaneously push through the contractions. And remember to gain consent to visually observe for the progress externally. The patient should respond to signals from their body telling them how and when to push. And how you can help is to offer Entonox to assist with pain management. In order to prepare for birth, we need to think about the environment and the equipment that we have. We need to be able to see what we're doing, so ensure that the lighting is adequate. Set the heating to maximum where possible, aiming for 25 degrees Celsius. We can help this by ensuring that windows and doors are closed. Keep the heating on in the back of the ambulance so that it's nice and warm when we're preparing to extricate. The immediate equipment that you will need are plenty of dry towels, your maternity pack, your thermal mattress, and a hat for the baby. Prepare an area for newborn life support. This should be a firm, flat area, ideally in the same room that the patient is given birth. All newborn life support equipment should be available, including airway adjuncts and neonatal masks. You should have a pediatric bag valve mask and also a stethoscope to listen to the baby's heart rate. Once you see the head visible, one clinician must have their hands poised in preparation for the birth of the baby. At the point of crowning, where the head remains visible and doesn't slip back in between contractions, encourage the patient to pant to slow down the birth of the last bit of the head. After the head is born, the baby's head should turn to the side between or during the next contraction. Following the birth of the head, allow the patient to spontaneously push, guided by their own body. Do not pull on the baby at any point. Support the baby as the shoulders and the body are born, then lift the baby towards the patient's abdomen. The umbilical cord may be around the baby's neck and does not require removal during the birth, as the baby can be born with the cord left in place. If the cord remains around the neck or body following birth, unloop the cord. The baby should be born within 2 contractions of the birth of the head. If this does not occur, then this is a shoulder dystocia and you'll need to refer to the shoulder dystocia guidelines. We're going to talk about optimal cord management. What we know is that 1/3 of the baby's blood is left in the placenta at birth, and this management enables for that blood to return back to the baby. Optimal cord management is evidence-based and is proved to improve short and long-term outcomes for the baby. Ideally, we'd like to keep the cord intact for the first 60 seconds whilst we dry and assess the baby. And if the baby is well at birth, then keeping the cord intact until it's gone white. We don't need to check for pulsation in that cord. If the cord is extremely short and prevents the baby from being held, then it can be clamped and cut at 60 seconds. We've moved away from immediate cord clamping, but in some circumstances this is important. So, immediately clamp and cut the cord if the cord is snapped. If the cord is snapped at the baby's abdomen, then apply pressure to the area and undertake a time-critical conveyance with a pre-alert. If the attached cord prevents the clinician from undertaking effective newborn life support, then the cord should be clamped and cut. And each cord should be clamped and cut for each baby if there are further babies to be born. The last baby can have optimal cord management. Here there are pictorial guides on how to clamp and cut the cord. So the first clamp is placed about 5 centimeters from the baby. The clamp is clicked into place. The second clamp is placed about 5 centimeters from the first clamp, and again the clamp is securely clicked into place. The cord is then cut between those two clamps. Be careful not to cut the genitals or fingers.
To assess the newborn baby, utilize the colour, tone, breathing, heart rate format. Due to differences in skin colour, it is best to check mucous membranes, for example the gums, for perfusion levels. The baby's arms and legs should show good tone. Respiratory rate would be expected to be between 40 and 60 breaths per minute. And on auscultation, baby's heart rate should be between 100 to 160 beats per minute. If baby is showing signs of central cyanosis more than 1 minute after birth, has poor tone, is breathing at a rate less than 40, or has a heart rate less than 100, you should follow the newborn life support algorithm. Third stage of labour, delivery of the placenta. Placing a clean Inco sheet under the mother will aid clinicians to assess any new blood loss. Taking and recording a full set of clinical observations will help with early diagnosis of postpartum hemorrhage. For example, mild tachycardia could be suggestive of compensated shock. Ambulance crews should make preparations to convey to hospital, such that, if placenta is still not delivered 20 minutes after birth, a time-critical conveyance with pre-alert to hospital should be undertaken. Actions to promote placenta delivery are such as baby being held skin to skin with mother, breastfeeding being supported where possible, encouraging the mother to pass urine, and ideally mothers should remain upright, as this will help with delivery of the placenta via gravity. Once the baby has been dried thoroughly, they can be held skin to skin. As previously discussed, this will ideally be with the mother, but if this is not possible, then an alternative would be another warm adult. Baby should be placed prone with face exposed and with a hat on and towel or blanket covering. If a thermal mattress is available, this should also be utilised to aid thermoregulation. A final consideration is that newborns should not be conveyed to hospital held skin to skin. Follow local procedures for safe transportation. Preterm babies, that is, less than 37 weeks gestation, pose a significant risk of death from hypothermia. Good thermal care is therefore of the highest priority. If baby is under 32 weeks or small enough to fit, they should be placed directly, still wet, into a plastic bag, making sure airway is still outside the bag, wrapped in a towel with a thermal mattress. If the baby has been dried already, then they can still be managed in this same way. Note, however, that a transient heat source is always required to utilize a plastic bag for thermoregulation. If none is available, babies should be dab dried to avoid damaging fragile preterm skin and kept as warm as possible while en route to hospital. All preterm babies should be treated as time-critical emergencies and conveyed with a pre-alert. In the out-of-hospital environment, labour with multiple babies should be treated as a critical emergency. Clinicians should request additional resources to scene, including, where possible, an advanced care team. NLS areas should be set up for each newborn, with a lead clinician identified to manage each area. Cords should be clamped and cut immediately, but last baby can have optimal cord management where this is clinically possible. After delivery of the first baby, the mother should be reassessed, and if, as is likely, contractions have decreased and next baby is not showing as birth imminent, the mother should be conveyed to hospital with a pre-alert detailing gestation and other pertinent factors, utilising an S-bar handover.
Amniotic sac presentation. Do not attempt to burst the amniotic membranes at any point prior to birth. This applies to babies of all gestations. Monitor continuously for any progress and undertake time-critical conveyance to the nearest maternity unit. If the sac bursts at any point, assess whether birth is imminent, observe for the presenting part, and act accordingly, as previously discussed. If the presenting part is a foot, feet, or hands, convey under time-critical conditions to the nearest maternity unit as per the breached guideline. If the head is presenting and the birth is progressing, stay unseen and prepare for birth as previously discussed. Born in the sac. Be sure to apply appropriate PPE. Once the baby is fully born, pull some membranes away from the baby's body using your index finger and thumb. Tear the membranes using your fingers. If the membranes are too thick to tear, use the tips of a pair of scissors from the maternity pack to carefully make a small incision in the membranes close to your pinched finger and thumb. Once ruptured, the amniotic fluid will rapidly drain away. Carefully peel the remaining membranes away from the baby's mouth and nose in order to ensure the airway is clear. Remove the membranes from the baby and undertake newborn assessment and thermoregulation. Note in the clinical record the status of the amniotic fluid, for example, clear, blood-stained, meicomium present, or offensive smelling. Birthing pools or baths. Attending and managing births in water is outside the scope of practice for ambulance clinicians. On arrival, you should ask the patient to leave the water and assist them to do so. If the patient declines to leave the water, inform that you are not trained. You do not have training in water births or training to resolve obstetric emergencies in the water, and this could result in a potentially poor outcome. Ambulance services also do not carry the equipment to monitor the water temperature, which is crucial for the baby's safety at birth. If the patient makes an informed decision to stay in the water against your advice, document all discussions and request additional resources to scene, anticipating the need to extricate the patient in an emergency. Warm the room and turn on the lights. Prepare several dry towels, the maternity pack, and set up an area for newborn resuscitation. Use appropriate PPE, sleeve protectors, gloves, wear eye protection and an apron. Continuously assess for imminent birth and continue to recommend to the patient that they should exit the pool if the birth or head is not advancing, or if there are new concerns such as meconium or fresh red bleeding. If the baby is born under the water, ask the patient to bring the baby's head above the water level. If the patient cannot bring the baby to the surface of the water, you must put your hands in the water, lift the baby up and ensure the baby's head is above the water so that the baby can breathe spontaneously without inhaling the water. Clamp and cut the cord. Move the baby out of the water and assess the newborn and provide newborn thermoregulation and newborn life support if required. Assessment and care of the patient and baby should be undertaken preferably by 2 separate clinicians or teams. Keep the baby in the same room as the patient, within eyesight if possible. Help the patient out of the pool, as the 3rd stage of labour should happen out of the water, and be sure to document all discussions and care management. Free birth. Free birth is when a patient chooses to give birth without any trained healthcare professionals present. Free birth is legal in the UK. Maternity service should be requested to attend even if the patient has previously declined their input. Provide clinical care and recommendations according to JRCALC guidelines. If the baby is born, care should be provided in the best interests of the child. If the baby is born, a midwife will be required for a face-to-face handover of care. Document all discussions and care provided, and escalate to senior clinicians within your organisation if necessary. Whenever possible, during conveyance, the baby should be secured in the ambulance. Do not use car seats for preterm or vulnerable babies. Ensure mum and baby travel to the same hospital where possible. At least 2 sets of observations on each patient should be undertaken. Use the pre-hospital maternity decision tool and act on any red flags identified after birth. Use of care of the newborn guidelines should also be.
Thank you for listening. If you would like to contact the United Kingdom's Pre-Hospital Maternity and Newborn Care Group, please utilise the email on the screen now. We would also like to take this opportunity to thank everyone who has contributed to the production of this updated guideline.